So next in our program, let me give you a sense of the research opportunities that you may have here at the College of Medicine. Susan Smyth, she is our chief of the Division of Cardiology. She also directs our MD, PhD training program as one of our finest educators. So I'll leave it to Susan here.
Again, I'd like to welcome you to the University of Kentucky and congratulate you on the hard work and accomplishments that got you in the audience and into our class. As you are celebrating this moment, I'm sure you're also thinking about the long road ahead in terms of the training. And as Chipper said, I do want to reiterate that I do not think there's a more noble profession than medicine, and certainly not one that suited my personality. And what I would like to convey to you is part of why I love being a physician, and that is because of the joys that I derive from biomedical research and being able to apply scientific evidence in the care of my patients. And so I'd like to take you through a little bit of the journey of why I think this is so important. So if you look at life expectancy in Western countries, in what I would term the scientific era, so that is from 1850s onwards, you can see that there has been a dramatic increase. So in the 1850s, average life expectancy was about 45 years. Today, we are approaching 85 years. If you compare that to the pre-scientific era, so if you go back 200,000 years and look at life expectancy 200,000 years ago, it was about 25 years. From there until the 1850s, it took about 10,000 years to increase life expectancy by 1 year. In the scientific era, we've been able to increase life expectancy in less than 5 years. That's the benefit of applying scientific evidence to the practice of medicine. It's not clear how much more we can extend life expectancy, but we certainly can translate what we've been able to accomplish in Western countries to other countries around the globe, and we certainly have improvements that we can all make in alleviation of suffering. And I like to give an example that's close to my heart as a cardiologist and someone who studies blood clotting, really to sort of drive home how this comes about. So I like to use the example of aspirin that was initially marketed for the common cold, still used today in adults, not children, but in adults for common cold. At the time that aspirin, over 100 years ago now, was initially marketed for common cold, it was felt to be safe because it didn't affect the heart. And so you will see in one of the first ads from Bayer, does not affect the heart. Well, we know now that's not true. And in fact, aspirin is one of the most commonly prescribed and used medications because, in fact, it reduces death and heart attack, which is the leading cause of death in the United States. And that transformation from a drug that was used to treat common cold to a drug that was used to reduce heart attacks and improve longevity in the United States largely came about by observations from physicians. So there were physicians that noticed that their patients that were taking aspirin tended to bleed. And they hypothesized that ability to thin out the blood might actually be able to reduce heart attacks. And so in the 1950s, studies were performed that demonstrated that aspirin, in fact, can reduce platelet aggregation. And so platelets are little cells that travel in the blood that when they aggregate at the site of an injury to a blood vessel, they form a clot. And when that clot blocks blood flow, one can have a heart attack, and one can often have a stroke. And so based on studies showing that aspirin thins out blood, causes you to bleed, inhibits platelet aggregation, studies in the 70s and 80s then were done to demonstrate that aspirin, in fact, is as potent as one of the clot busters, a thrombolytic that was used in the 1980s to treat heart attacks. It was as potent as an incredibly powerful drug that destroys clots completely in terms of preventing death after a heart attack. And so now today, my society, the American College of Cardiology, has undertaken a campaign in which they're using the ABCs: aspirin, blood pressure control, cholesterol management, and smoking cessation, to try to prevent 1 million heart attacks and strokes in 5 years. This story that I'm telling you was largely driven by physicians' observations. It started with observations in their patients, and then that got percolated into clinical trials that physicians performed to demonstrate the benefits of aspirin. If we look historically, using other markers, so for example, if one looks at the percentage of Nobel laureates in medicine or physiology that were physicians, at the turn of the century, about 80% of individuals receiving the Nobel laureate were physicians, and they were receiving the Nobel laureate for innovations that really transformed clinical care and medicine. If you then look in the 2000s, more recently, less than 20% of Nobel laureates now are physicians. There are other data that really support the fact that there's been a decline in the participation by physicians really in driving biomedical research. So here are data that look on the top from the 1980s until more recently 2012 at medical student interest in research. And if anything, it's been growing, particularly in the last several years. And yet if you look on the bottom graph at the number of physicians that are as a percentage participating in research, it's actually been declining. And so as a result of these types of observations, a number of people, leaders in medicine and biomedical research, got together a number of years ago to really try to understand why there was this widening gap between biomedical research that was being done at academic and leading universities and its application into clinical medicine. Because for most of us, the reason we're participating in biomedical research really is twofold. One, to increase knowledge, but really two, to improve human health and alleviate suffering. And so as a result of this recognition that there really was this widening divide between the practice of research and its application to human health, the National Institute of Health some years ago decided that they were going to fund 60 academic institutions that would really be the hub, the nidus where the next generation of biomedical research would be done, where individuals would be trained, and these would be the centers that really would drive the forefront for clinical and translational research and be able to take basic observations that were performed by scientists, physicians, and apply that to improve human health. About 5 years ago, we, as the University of Kentucky, applied and were successful in receiving one of these grants from the National Institute of Health to establish a center for clinical and translational science here. So it turns out they funded 61, and so we're one of 61 sites that really serves as the lead to be able to drive clinical and translational research and improve human health around our country. And so as part of this Center for Clinical and Translational Science, there's a very large focus on educating future workforce. And that future workforce starts with folks in our medical school class, because it really is essential that we re-engage physicians at all levels, whether they're in academic medicine, whether you end up in government or advocacy, whether you're in private practice and primary care, that physicians at all levels are really engaged in the process of applying scientific evidence to the improvement of the health of their patients. And so in order to do this broadly at the university, we have set up a series of programs targeted largely for medical students. This includes summer research opportunities that you can all participate in. We have an Introduction to Clinical Research course The course is offered in the summer, so you can take it next summer before you enter medical school. It's also offered as an elective in the spring semester of medical school, and so you can, if you don't have the chance to take it in the summer, you can take it in the spring as an elective. And then once you complete the Introduction to Clinical Research, you can then apply for a one-year professional student mentored research fellowship. This one-year research fellowship involves working closely with a mentor on a research project where you receive $3,000. The $3,000 goes to you as a student. It doesn't go to your mentor. It doesn't go to PACE supplies. It really is a way for us to incentivize and encourage students to participate in the research process. We also have other supplemental seminars and conferences where we gather the students together to talk about their work and to be able to present their work and get feedback and recognition for what they've accomplished. Since we've introduced both the ICR course and the fellowship program, we've seen a dramatic increase in the number of students that have participated. And at our recent LCME accreditation, when we surveyed the students, as Chipper mentioned, 2/3 of the students indicated that they were engaging in some type of research during their medical school process. Several students and Drs. Sawaya and Kelly, who direct the PSMRF program, looked at what was the impact of this program on the medical student experience. And so they looked at a cohort of students during the time frame when we offered the fellowship. They looked at students that completed the fellowship versus those that had not. And in terms of entry, MedCat scores, STEP exam scores, the students look, for all purposes, very similar. What they observed, however, was if you look at the students who completed the fellowship program, they were twice as likely to be inducted into that AOA Honor Society. They were also about twice as likely to match in one of a top 25 residency program. And so in addition to the knowledge that you gain, there are practical benefits, I think, from participating in these research fellowship programs in terms of positioning you for the next phase of your career. I also believe that by understanding in more detail how one evaluates the scientific literature and how one can then apply it to one's patient, you will be a better physician whatever path you choose. Whether you're in primary care, whether you become a surgeon, whether you are, as I said, an advocate, someone who works for the CDC or in the FDA or in academic medicine, you will become a better physician by understanding how one applies evidence in what we do every day. In the last few minutes, I just want to brag on some of our students because our students do tremendously well. They've published in all of the leading journals. Not only have they published in the leading journals, but their work has been recognized by the leading journals as being the best of the best. So Romulo Albuquerque, one of our students who graduated several years ago, who's now remained here in ophthalmology doing his residency, discovered a novel protein that regulates how lymphatics develop. His paper was published in Nature Medicine, which really is the home of translational research for those of us who do translational research. His paper was picked as the top article in cardiovascular disease to have been ever published in Nature Medicine. Likewise, Ben Fowler, about a month ago, had a lead article in Science where Ben described how reverse transcriptase inhibitors, drugs that we've used for many years to treat HIV, have anti-inflammatory properties that make them suitable to treat and prevent macular degeneration, leading cause of blindness in the United States. So application of an old drug to a disease that needs a new treatment that may very quickly be approved. And then Mary Burchett, who grew up in Kentucky and was diagnosed with Marfan's as a child. In order to be diagnosed, she had to leave Kentucky because at the time we didn't have the type of quaternary care that Chipper described that we now have here today at the University of Kentucky. Mary's lifelong dream was to train as a physician to change that and to be able to bring services here to the University of Kentucky and across our state so that others didn't have to leave our state. We're very proud of the fact now that we can say that folks do not need to leave Kentucky in order to receive the most advanced, the most state-of-the-art treatment. While a medical student here, Mary continued her interest in marfans and identified novel expression of isoforms of the protein fibrillin that regulate the development of marfans. Our students have won all types of national awards, so they're recognized not just here in our state, but across the country for their contributions to improving scientific knowledge and translating that information to improve health and alleviate suffering. And so I'd just like to leave you with this image where I do really believe that here at the University of Kentucky, our students, our residents, our faculty are bridging that gap between basic science and its application to clinical medicine, and that we really are a hub for where this will continue to happen for our nation as a whole. So I'd like to, again, congratulate you. Thank you for the opportunity to speak with you. And now I would like to introduce one of my colleagues in internal medicine, Christopher Feddock, who several years ago, our dean, who's a very astute individual, recognized the top talent around the campus and borrowed Dr. Feddock out of internal medicine to have him become the dean of curriculum. And while we were very sad to see him leave his role as residency director in internal medicine, he really has now, across our college, had a major impact in terms of the revision of curriculum and the improvements in the college that have occurred. And so I'd like to introduce and welcome Dr. Feddock up to speak on curriculum.